frequency content of the signal that corresponds to the muscle response to the simulation, and then we have continuous wavelet transform that has the best time frequency resolution and shows a more continuous representation of the frequency content of EMG signals. So, so here is an example of how when two signals in assisted standing and independent standing look very similar in the time domain. The first graphs are the time domains, but when we calculate the wavelet, the time frequency domain, we can see that there is significant difference between how the wavelet outputs look like. And if we calculate the median frequency for the wavelet, you can see the mean value and the standard deviation of the instantaneous numbers, they change. So overall, we calculated several features for the spectral analysis. The total power that can be both calculated in time and frequency domain. We calculated the median frequency, the peak power frequency, and the peak power amplitude. So in the first step, we calculated to see if there's any significant differences between these features and between different standing conditions. So the first one is hip and knee assisted, second one hip assisted knee independent, and the third one hip and knee independent. And you can see and we consider all the muscles together, only extensors and only flexors, and in most of them there is significant difference. So the next step is the classification step. In order to perform classification, we had to logarithmically transform the data to stabilize the variance and make a normal distribution, make the data to be normally distributed. We also applied the non-negative matrix factorization for dimension reduction, because we have 13 features. And then we use the K-nearest-neighbor classification method. And you can already see here that the wavelet features, these plots are the first 3 dimensions of the non-negative matrix factorization, and you can see the wavelet transform occupies the first 3 dimensions, whereas the FFT only occupies the first 2 dimensions. So it already tells us that wavelet is providing more information. And the STFT is somewhere in the middle. So this is the accuracy of the classification for the 3 methods, and you can already see that the wavelet has higher accuracy. And we also calculate the accuracy for all the muscles together and each individual muscle, which with Solis showing the highest classification accuracy. The last part is the prediction. So we trained the network, we trained a model with all the data that we had, and then we test the model with some of the data that has been assigned as all assisted, but we want to know if there are different level of assistance within the EMG signals. And this method shows that, for example, using this configuration, using the second configuration, you can achieve up to 60% independence in the signing, even though this is something, it didn't lead to an independent signing, but this method gives a prediction that this configuration has the potential to lead to an independent signing. So overall, what we found out is that the wavelet transform gives us additional information to FFT and SCFT for a spectral analysis of the EMG signal. And we found out with the epidural stimulation on, when the standing reaches independence, the the average frequency is lower. The standard deviation of the frequency is also lower. The total power goes high, and the max power coefficient is also going down, has a trend to go down. The classification with all the muscles can reach 93% accuracy in classifying independent from assisted standing, and the soleus muscle has the highest accuracy of 96%. The classification model can be used to predict the stimulation, the best stimulation parameter that can lead to independent standing, and these findings can help experimentalists with their effort in finding the best stimulation parameters, because in a lot of the cases the subjects they have to go through several sessions. Sometimes they look for months to find the best stimulation, and it's a very exhaustive search, and this extra information about the muscles can help them to reach their goal faster. So these are the people from Spinal Cord Research Center that we collaborated with: Susan Harkema, Claudia Angeli, Enrico Rage, and Federica Ganelli. And those are the first 4 participants that participated in this study.
One question. Any question?
It's not my field, so my question may be ignorant, but when you say voluntary movement, does it mean it comes from the brain? The command comes from the brain?
Yes. So
it's not because of the electrodes that you insert on the...
It is because, so when the stimulation device is on, it basically what it does, it excites the spinal circuitry, or it brings its excitability level to a point that the signals that are generated by the brain can activate those spinal circuits that can lead to voluntary movements. So they have tested the subject before the stimulation are on, and those videos are on YouTube if you look them up, and they can't move anything, any of their muscles, and once the stimulation is on, and the stimulation is at the level that doesn't cause muscle response, it's at pre-threshold level, but it excites the spinal circuitry, and then the spinal circuitry can respond to that weak signal that comes from the brain, and it allows them to move their limbs.
Just one short question and short answer.
So for the feature selection, how many features did you start with? How many did you reduce it down to? And I noticed that on your KNN accuracy, you had several different muscles that you put that in. Are those the features that you're looking at?
No, the features are like the total power, the instantaneous frequency. We calculate the mean and standard deviation of those. So in total, there are 13 features. Then we train the KNN model on all the muscles together, or we train them on individual muscles separately to see.
They're not related to each other, like the features in the KNN classification.
They are all the same features, but the number of features would increase when you have all the muscles together, whereas you have only a single muscle.
Thanks for the speaker again. Our next speaker is Kiana McKinsey from Louisville, and her presentation title is Investigating Potential Fractures in Feet First Falls Using an In Silico Pediatric Tumor.
Thank you for the introduction. Once again, I'm Kiana McKenzie. I'm a PhD student at the University of Louisville. I'd like to thank the NIH for funding this project. Clinicians, law enforcement, and social services personnel are often faced with determining whether a child's injuries are the result of physical abuse or accidental causes. Presently, these determinations are often based on experience and opinion, while biomechanical evidence regarding the likelihood of observed injuries being associated with the stated cause can aid in the diagnosis of abuse. So clinical case studies have aimed to determine whether injuries are due to accidental or more likely to be due to abusive causes, and they made findings such that household falls are both a common accidental injury mechanism as well as a common falsely reported cause in cases of abuse. Femur fractures are a common injury to be seen in these household falls, but they're more likely to be due to abuse in non-ambulatory children. Previously, we conducted fall experiments where using a modified crabby 12-month-old ATD with an improved biphidelic femur. So what you see on the image on the left here is the ATD falling and hitting the ground, and it was dropped from a height to do that. So from these, we were able to characterize the femur loading and simulated first falls from a height. And the different fall configurations included falls onto two different impact surfaces, linoleum and padded carpet, more common surfaces you might see in the homes and whatnot, and from two different fall heights of 69 and 119 centimeters. The purpose of the study was to develop a finite element model of the pediatric femur to evaluate potential fracture risk using loading conditions from the ATD experimental fall data previously described on the last slide. We did this by obtaining the femur stress and strain distributions associated with these feet first falls, and then compared those outcomes to fracture thresholds to determine fracture potential. So first we took a CT scan obtained from the University of New Mexico of a healthy 11-month-old child, and it's kind of hard to see, but the red here is an example of the segmentation of it from the CT scan, where we segmented it from the CT scan using 156 Hansfeld unit threshold and mimics, and then we exported it to 3-matic to create a 10-noded tetrahedral mesh. To apply the material properties, the first step is to generally use a phantom calibration insert to be able to determine the bone mineral density, but this scan lacked one of those. So we used other CT scans to do a phantomless calibration method where they had phantom calibration inserts and used that to develop the Hounsfeld unit bone mineral density relationship. These material properties were applied of the parent density, elastic modulus, and cross-on ratio in mimics. And this is similar to a procedure by other subject-specific finite element model femur evaluation studies such as Scaleto in 2008. This was then exported to ANSYS to be evaluated for finite element analysis, where first we applied the Crabby ATD coordinate system to be able to correspond to those load cells of the ATD femur assembly. The constraints applied was that at the proximal end of the femur up here, a singular node was fixed for translation in all directions, and the rotation was fixed along the longitudinal axis. At the distal end, we constrained the intercondylar region, which is this region here, to have fixed displacement, and we apply the loads at the location B shown, whereas approximately where the load cells were located in the ATD femur assembly. So a 6th degree of freedom loads were applied at their corresponding locations from the ATD data set for a total of 12 total ATD fall trials that were evaluated, 3 for each of the scenarios, so the different combination of impact surfaces and fall heights. So an example of that time history is on the top you have the time history of the forces for a trial and the corresponding time history of the moments on the bottom. On the left you have the 2 primary impacts that we really want to look at. Is one, the initial impact of the feet just hitting the ground when it drops, and that's where you see your peak compression forces. And then the second impact occurs when the pelvis hits the ground, and this is really where you see your peak bending moments being applied to the femur. To evaluate whether the trial would result in a potential fracture, we considered 3 different fracture thresholds: a tensile yield strain, an ultimate flexural strength, and an ultimate tensile strength. where these strength thresholds were taken from pediatric bone properties data in the literature. Additionally, to evaluate the effect of fall height and impact surface on fracture potential, ANOVA and Tukey tests were used to compare the outcomes for the different fall configurations. Oh, and to determine whether the trial had potential for fracture, we also added an additional criteria that a minimum of 5 congruent elements must have exceeded the threshold in order for it to be classified as having the potential for fracture. So the figure on the left is the peak maximal principal strain for the 4 different scenarios, and on the right is the principal stress, maximal principal stress. The greater fall heights are encircled in red just to kind of help you visualize that a bit better. The results of the ANOVA indicated that there's significant difference between the fall heights for these outcomes, while there's no significant difference between the impact surfaces. So a refresher on those fracture thresholds, we have the tensile yield strain, the ultimate tensile strength, and the ultimate flexural strength. And you'll notice some of these trials do numerically exceed these threshold values, but they didn't meet that additional criteria of having a minimum number of congruent elements having exceeded that threshold. So none of the trials that we evaluated met the requisite criteria to be identified as having potential for fracture. These results suggest that there's a low potential for fracture when considering all the criteria evaluated, and these first falls from the heights evaluated. The FE predicted stresses and strains were found to be influenced by fall height, but not by impact surface. These findings are consistent with the clinical case studies currently out in the literature, where femur fractures are typically found in falls greater than 4 feet, but from the heights evaluated in our study, which was a maximum of 119 centimeters, or about 47 inches, they're not likely to result in a fracture. Previously, only 2 studies have evaluated infant femur fracture through finite element analysis, Lee and Altai, where they applied only pure bending or pure torsional loads, and they predicted fractures at bending moments of 24 Newton meters and a range of 8 to 13 Newton meters for torsional loads. While in the current study, the peak bending moment of the ATD loads that we evaluated was 19 Newton meters and 8 to 11 Newton meters for the torsional loads. Although we did have trials that were similar with those previous studies with fractures, we did find that they had exceeded, the ones that were in this range of torsion had exceeded the fracture thresholds, but they didn't meet that additional criteria to be classified as a fracture. In addition, this torsion was typically associated with the ATD landing on the ankle and twisting and having it flipped, so it was potentially associated with the fall dynamic that is less realistic of an actual child impacting the ground. So a few limitations of the study is the resolution of the CT scan isn't usually the level that most subject-specific finite element modeling evaluating fracture would use, which results in partial volume effect errors potentially, which reduces the Hounsfield unit along the boundary of the bone due to the occlusion of both soft tissue and bone in these voxels. In addition, there really are a lack of studies defining the pediatric mechanical properties, especially those that have been applied and validated with finite element models. We also applied a linear elastic material model that was taken from studies that were evaluating adults. While we assumed that the modulus density relationship that we used would still be maintained for this age of 11-month-old, this still hasn't been validated, nor has the accuracy of the fracture thresholds have been validated in children as well. We also didn't account for any viscoelastic effects that may have occurred in affected material properties, and there still may be limitations in the ATD biofidelity as used as inputs to this finite element model evaluation. In conclusion, the pediatric femur finite element model was developed and used to simulate a common household fall scenario, feet first falls, and this was conducted using experimentally measured loads, where we found that an increased fall height was associated with an increased risk of fracture, although we didn't observe fractures on the current heights we evaluated, and an impact surface did not significantly affect any of the outcomes we evaluated. This study highlights the need for a thorough history of injury mechanisms to assess fracture potential. Currently, it's in the literature, you may not necessarily find the level of information about the exact scenarios that these femur fractures occurred, so making sure that whoever encounters these children notes factors such as fall height when they're reporting to determine whether these are abusive or accidental scenarios is still necessary. However, there's a need for improved pediatric bone material properties and fracture thresholds for further validation of the finite element model and its applicability. Questions?
So you used a linear elastic model, right?
Mm-hmm.
Did you use like a failure theory, or did you just look at the peak stress of the
I just looked at the peak stresses, just because we don't know how much of the adult data modeling applies to pediatrics. Using a more kind of linear model for now seems kind of the safest approach. And the studies that have used linear elastic models have found it does correlate pretty well with fracture when you use the tensile yield strain threshold. So for an initial evaluation, we felt that this was appropriate.
Okay, thanks again. Our next speaker is Nathan Brown from University of Louisville.
Sorry.
Development of a rigid body musculoskeletal computer model for evaluation of gain in a healthy and neurologically impaired total dystrophic dog. I'm not sure.
Thank you for the introduction. Again, my name is Nathan Brown. I'm a research engineer at the University of Louisville in the Department of Bioengineering. Again, I have another long title here in state development of a rigid body musculoskeletal computer model for evaluation of gait in a healthy and neurologically impaired chondrodystrophic dog. First off, I'd like to acknowledge the Canine Health Foundation for the grant funding, as well as support from the Louisville Biomechanics Endowment. So first off, a little background on canine intervertebral disc disease may lead to intervertebral disc herniation, which I'll refer to as IVDH from now on, which can cause spinal cord injury, paraplegia, and other long-term disabilities. 2-3% of dogs suffer from IVDH during their lifetime, so it's pretty prevalent. And this risk of IVDH is significantly higher in chondrodystrophic breeds such as Dachshunds, Shih Tzus, and Pekingese. Dachshunds in particular, up to 19% are affected in their lifetimes. This creates an opportunity for a unique translational break between human and canine, in that for canines the injury is naturally occurring. This breed in particular is very popular, and also there's some injury mechanisms, pathology, and outcomes in humans. So also, if we look at the injury in particular, the intervertebral disc is this cartilaginous structure located between the vertebrae. It provides support, flexibility, and cushioning against mechanical loads. The increased mineralization of the nucleus pulposus results in mechanical failure of the disc. So if you look at the image on the right, we can see the nucleus pulposus has actually extruded out beyond the annulus fibrosus, leading to impingement on the spinal cord nerve root there. This IVDH often leads to gait dysfunction. However, this gait dysfunction is often measured using numerical scores to categorize observed movements, but these scores are often subject to assessor interpretation with minimal qualitative evaluation of gait. Also, no current scale quantifies muscle recruitment and muscle activation necessary to perform that gait, and some of the finer details of the recovery process may be lost, such as compensation by any particular muscles. One approach to possibly get around some of these issues is to use musculoskeletal modeling, and this has often been used to understand underlying control of movement and biomechanics at the level of individual muscles. These models can include muscle mechanics, bone geometries, kinematics, kinetics, and so on. These muscles can also calculate variables that are difficult or impossible to measure in vivo, such as joint moments, muscle activations, and forces. And analyzing these additional measures could allow for a deeper understanding of the recovery process. The goals of this study are to develop subject-specific dynamic rigid body musculoskeletal computer models of the pelvis and pelvic limbs in a healthy dog and a dog with IVDH, in particular in a chondrodystrophic breed. Also to describe pelvic limb kinematics during walking gait and estimate muscle activation patterns during walking gait. It's hypothesized that model predicted kinematics will differ between the healthy and unhealthy dogs during gait, and additionally muscle activation patterns will also differ. For this study, 2 canine subjects were recruited, 1 healthy, 1 unhealthy. So first, the healthy dog was a 2-year-old Klein-owned female dachshund, had no evidence of neurologic or orthopedic disease. For this dog, a full body CT scan was performed. Walking gait kinematics and kinetics were collected. The other dog, an unhealthy dog, was a 6-year-old Klein-owned female dachshund that had T13 IVDH receiving hemolaminectomy decompression surgery. For this dog, additionally, a full body CT was performed at pre-surgery, as well as 90 days post-op, when the dog was ambulatory. Walking gait kinematics and kinetics were also collected at that 90-day time point. So we can see here, it's a little tough to see that dog, but on the right, we see that dog has some markers adhered to the pelvic limb. And so we use these markers to collect kinematic data. Performed 10 walking trials where the dog was walked in a straight line forward at self-selected walking pace, and we used the motion capture system to collect this data. Kinetics were also obtained using 2 force plates, 2 force platforms that were placed level with the ground, also placed adjacently, and this allowed for the dog to walk across both plates so that we could isolate an individual paw on each plate. And one gait cycle is defined as paw strike from one paw until subsequent paw strike from that same paw. So next, for the computer models, 2 custom computer models were developed. One for the healthy dog and one for the unhealthy dog at the 90-day time point. Some inputs to that model. So first we segmented the CT scan. From that we could delineate different tissues, including the cortical and trabecular bone, muscle, and fat. And from this, 9 bony segments were generated, including pelvis, as well as the bilateral femur, fibula, tarsus, and phalanges. So if you look here on the image on the right, we can see those muscles that were segmented at the very top image, and then the one below that shows an individual bony segment with coordinate system applied, and those coordinates were aligned with the anatomical axes. Additionally, some inertial properties could be determined based on the distribution of the tissues within the scan, including volume of each tissue as well as the various mass properties. Some other components were the joints. So we've got the hip, stifle, tarsal, MTP or metatarsal phalangeal joint. And then each of these joints were defined to allow for different degrees of freedom. So the hip was allowed 3 rotational degrees of freedom, flexion, extension, abduction, abduction, and internal external rotation. Stifle and tarsal joints, or the knee and ankle, were modeled as single degree of freedom rotational joints, allowing flexion and extension, as we can see on the image on the right. And then the MTP joint was fixed. 23 bilateral muscles were involved that are involved in gait were included, as listed there, so I won't go through that list. But some individual parameters for each of those muscles was determined, including the pronation angle of the muscle fibers, maximum isometric force, muscle fiber length and the slack length, origin and insertion locations, as well as the line of action of each muscle. The computer model is developed in a freely available open source software called OpenSim. This is a biomechanical modeling and simulation software, and then within that software, three analyses here were conducted, including inverse kinematics, which aligns the computer model with measured kinematics based on marker trajectories. Next was to perform a residual reduction algorithm, which minimizes modeling errors that lead to dynamic inconsistencies. And then finally, a static optimization, which determines muscle activations and forces that could generate the joint torques from ground reaction forces and inertial effects. So this shows the computer model that was, the healthy dog model that was developed. So we can see each of those bony segments as well as the muscle lines of action. A little tough to see that red, but you can see those individual muscles there. Got a couple of videos here just to show an individual step cycle. So we can see the dog is walking across these two force plates towards a staff members there. So again, it's just one step cycle. Pretty quick, and then video on the right just shows the same step cycle within the computer model. So looking at some results and discussion here. First off, the kinematics. So stance and swing kinematics differed in terms of timing and magnitude, but the healthy and unhealthy dogs, between those two, the waveforms, trends, overall trends were similar. Some other things that we can note here is that the unhealthy dog, the hip joint demonstrated some increased extension, and then the other item here is that flexion of the knee and ankle are delayed at the transition from stance to swing. So we see a slight offset there. So further, in the unhealthy dog, increased hip, stifle, and tarsal joint extension at the start of stance or during weight bearing could indicate that the unhealthy dog maintained a straighter or stiffer leg. So we see that basically at the start of our plots, the unhealthy dog, the red curve, is more extended, so it has the greater values. The next point there is that these kinematics could be a compensatory mechanism to provide limb stability and or reflect changes in underlying muscle, spindle, and force feedback systems. So now it's going to look at the muscle activation patterns that we're seeing in healthy and unhealthy dogs. So what we have here are 6 major muscles that were included in the model, and then we've got healthy and unhealthy for each. So healthy is in black, unhealthy is in red, and then we're looking at each of those muscle activation patterns throughout the gait cycle there. So just some human analogs in terms of what these muscles are or what they represent. I've listed those there. And then what I wanted to point out were some similarities highlighted there in blue. So these are sections where we see similar either activation or lack of activation occurring between the healthy and unhealthy dog. And the one I was going to point out is the middle gluteal we see active in both scenarios, or in both dogs. And this one makes sense because where it's active is during stance or towards the end of stance, and that is when the middle gluteal is extending the hip. So it makes sense that would be the most active at that time. However, there are some dissimilarities that we can see where the two don't necessarily show any type of correlation there. The one I was going to point out here is with the rectus femoris. We can see that in the unhealthy dog, rectus femoris is quite active in comparison to the, it's quite active in the unhealthy compared to the healthy dog. So this could possibly be some type of a compensatory mechanism within that dog. Trying to tie this all together, some clinical significance is that if we can identify some muscle activity or maybe even lack of activity during gait, this could aid in determining muscles to target for rehabilitation purposes. Also, the findings in dogs could potentially translate to human rehabilitation, as was indicated previously. So some of these same principles can be applied in humans. There are some limitations with this work. It is some preliminary findings. First off, we have one representative gait cycle from each dog. So we'd like to increase that number. Some muscle characteristics were determined from other non-combat destructive breeds, from other studies, and also the evaluation of other IDVDH injuries and severities may lead to some different findings. So a dog with a different type of injury level could have a different gait pattern and lead to some different findings. In conclusion, these are the first musculoskeletal models developed to assess spinal cord injuries in dogs that allow for a better understanding of muscle activation. The gait kinematics and muscle activation patterns differed between the healthy dog and unhealthy dog. Musculoskeletal computer models predicted increased hip extension and increased rectus femoris activation in the unhealthy dog. And finally, these preliminary findings could indicate a functional compensatory mechanism in the unhealthy dog with IVDH. Thank you. Are there any questions?
Questions?
So you had an N of 1 for healthy and unhealthy. So how representative is just having 1?
Ideally, we would have more, but this is a good first approach first step in terms of developing the approach, so where we could start to tease out some differences between healthy and injured. But one thing I haven't shown here is so we only looked at the one time point, but another step in the future is to look at an additional time point to help better illustrate the recovery process.
Thanks, okay. Our next speaker is Mustafa Meki from University of Louisville. A sensorless nonlinear control algorithm for continuous flow right ventricular assisted devices.
Hello everyone, my name is Mustafa Meki, and today I'll be presenting a sensorless nonlinear control algorithm for continuous flow right ventricular assist devices. So if we're talking about ventricular assist devices, we must start with heart failure. It's a progressive disease where the heart loses its function or some of its function and ability to pump blood into the vasculature. It's the leading cause of mortality in the United States, with 6.5 million patients currently and a projected 8 million in 2025. The gold standard for patients with heart failure is receiving a heart transplant, but due to the paucity of donor organs, mechanical circulatory support, or more precisely ventricular assist devices, have become a standard therapy for advanced heart failure patients. Controlling VADs has been done clinically, or the clinical standard in this case is using a constant reference speed point, which is set by a clinician based on clinical outcomes. However, this is not very efficient because first of all, it cannot adjust to increase tissue demand. So think of exercise versus rest. It also cannot adjust to reduce preload, and these are conditions where the heart is not filling as much, so the ventricles are more susceptible to collapsing. Other control schemes have been proposed in literature. Some of them have used sensors, so basically they implant a sensor, a pressure or a flow sensor, maybe both, as feedback to obtain a physiologic control. However, these sensors are subject to sensor drifts, and explantations, if they fail, would require open heart surgery. Sensorless control algorithms have also been proposed, where they would use a model-based parameter estimation to use the pump speed or other signals to estimate the pressures in the flow, and then use these to provide physiologic control. However, these are also complicated, and they're affected by the changes or the variations in the blood and pump models parameters. So typically, a heart failure patient would have left-sided failure, where the left ventricle is the one failing to eject. However, the right ventricular failure can also happen in conjunction with left ventricular failure. Also, there's a plethora of diseases and chronic conditions that can cause right ventricular failure, such as pulmonary hypertension, COPD, and congenital heart diseases. So as you can see in this figure, this shows a right ventricular assist device that is taking blood from the right ventricle and pumping it back to the pulmonary artery. So for our design, we set our goals to develop a control algorithm for right ventricular assist devices that is able to provide physiologic perfusion. So that means it will adjust the pump flow depending on the tissue demand. And also it would prevent ventricular suction, which can occur during reduced preload. So these are conditions, for example, during a Valsalva maneuver. I don't know if you know this, but this is when someone is defecating. It also can happen during coughing or a rapid transition from exercise to rest. So all of these can cause cardiac tissue demand and trigger arrhythmias once you fall into that this suction. So the second objective was we wanted the control algorithm to be sensorless. We also wanted it to be directly applicable to any continuous flow ventricular assist device that is FDA approved out there without any changes to the pump design or the pump parameters. It's important to note that controlling or unloading the right ventricle is more challenging than the left ventricle, and this is mainly because of the anatomy of the right ventricle. So as you can see from this figure, the right ventricular wall is much thinner, and it has more sensitivity to afterload, which makes it more susceptible to suction events. So we built our hypothesis for this control algorithm mainly based on these two figures you can see. The first one, they're basically saying the same thing. The top one is from the hardware HVAD training manual, which is one of the clinically approved ventricular assist devices. So as you can see, as you move to the right, the pump is unloading the heart more. So the more you unload the heart, the less the less variation in the pump flow and the pump speed you're going to get. So what I mean by variation is the pulsatility, or the max minus min. So when you get closer to suction, this delta RPM or delta Q is going to decrease. But when you don't unload the heart as much, you will move towards hypoperfusion, and the delta RPM or the delta Q will increase. So we have this hypothesis that maintaining differential pump speed and at an appropriate level can provide both physiologic perfusion and avoid suction for RVADs. So this is a schematic of the proposed algorithm, where we would measure the pump speed using phase currents or using Hall effect sensors, which do not come in contact with blood, and then obtain this signal and measure the average differential pump speed for the past 1 to 3 seconds, and then compare it to a single delta RPM reference point. If it's higher, then you need to increase the current to unload the heart more. If it's lower, well, then you need to back off and decrease the current so you don't fall into suction. So we implemented and tested this algorithm in silico using a computer model. We used the lump parameter model of the circulatory system that depicts the circulatory system as discrete blocks of resistance and compliance. And then we coupled it with a nonlinear dynamic model of the HeartMate 2 VAD, which is a clinically approved pump. For the test conditions, we had first baseline test conditions with normal and failing heart without assist. And then we compared the delta RPM controller, which is what we're proposing, to the clinical standard using constant RPM under rest and under exercise conditions, and with a 30% increase in vena cava resistance, which should simulate a reduced preload condition, which is more prone to suction. So we implemented this algorithm using a gain schedule PI controller. As you can see here, these are the different parameters. We said one reason why we had to use a gain schedule controlling instead of a normal PI controller is because to kind of account for the susceptibility of the right ventricle to suction. So once the delta RPM falls below a certain value, you want to artificially increase the preload sensitivity of the ventricle and the pump. So these are our results. So if you look at the first 4 rows here, these are controls with a normal and failing heart without assist. You can look at the flow rates here with 5.1 and 8.5 for the normal heart. So that's liters per minute, the total output from the right ventricle. For the failing heart, these values drop to 3.7 and 6.4. So simulating rest conditions, as you can see with the delta RPM controller and the constant RPM, we had fair unloading of the heart with 5 liters per minute for both test cases. So both performed well. However, once we move to exercise, the delta RPM control provides 8.3 liters per minute, so compare that to the 8.5 in a normal heart. However, the constant RPM controller only provided partial support, so that means that the pulmonary artery, the pulmonary valve was opening and could only provide 7.73 liters per minute. The third condition with the reduced preload and 30% increase in vena cava resistance, it's more interesting to look at the right ventricular end-diastolic pressures and the minimum right ventricular pressure. So for the delta RPM controller that we're proposing, we have an end-diastolic pressure of 4.3 millimeters of mercury and a minimum of 3.5. But looking at the constant RPM control, this value falls all the way to 0.52 and 0.34 millimeters of mercury, which is less than 1. So this is an indication that suction is happening. So to reiterate, these are the waveforms for pressures and volumes. This is for the rest conditions, where you can see the two algorithms were able to perform fairly similar. However, if you look at the pressures here, the pulmonary arterial pressure and the right ventricular pressures are coinciding, which means that the pump with just a constant speed reference point was only able to provide partial support. For vena cava resistance, a 30% increase in vena cava resistance, the right ventricular pressure for the delta RPM control, so the 30% increase in vena cava resistance was initiated at T equals 150. The right ventricular pressures and the right ventricular volumes began to dip, but the controller soon recovers in almost 40 or 50 seconds. And the same goes with the pump flow rate and the pump speed. However, looking at the constant speed control, it does not recover, and the right ventricular pressure falls all the way down to 1 or 2 millimeters of mercury and stays down, and the right ventricular volume also falls down. Looking at the pump flow rate and the pump speed, the delta RPM, which is the indicator of suction, as we looked at the hardware HVAD, also decreases and stay low, which means that constant suction has happened. So all in all, these results are promising, and they show the feasibility of using only a single delta RPM reference point to obtain both physiologic perfusion and avoid ventricular suction. We have also been able to demonstrate the superior performance of using delta RPM control as opposed to a constant RPM control during rest, where both were able to provide the same perfusion, and exercise, where the delta RPM control was able to provide full support at 8.3 liters per minute, and no suction events happened with reduced preload. Again, the susceptibility of the right ventricle to suction required us to use gain scheduling to artificially increase the preload sensitivity, and this controller does not require unreliable sensors or complicated parameter estimations. Last thing is to discuss the limitations. First of all, this algorithm can only be used as long as there is some reserve contractility of the ventricle, because if the ventricle or if the heart is not beating, then there's going to be no variations in the pump flow or the pump speed. However, it's very easy to detect such cases and apply a safe mode. Again, the limitations also with the model we used. It assumes Newtonian fluid, ideal heart valves where there'd be on and off, so it's kind of basically a logic valve. The outflow cannula resistance was not accounted for. Also, it does not cannot model graft kinking due to the beating of the heart. Also, cannot predict all clinical responses due to neurohormonal stimulations or baroreceptor reflexes. So ultimately, we will need marked circulation in animal testing that has to be performed. But it's important to note that this model has been used extensively in literature, and the results have been similar to results obtained from animal models. And for this work, we've been able to obtain a provisional patent, and we think it's a very simple solution to a complicated problem. So that's the novelty of it.
No more questions? Yes. Thanks, Peter. This is a long section. The good news is we have a last speaker, and the speaker is Salia from University of Louisville. I'd like to present the title.
Alright, good evening everybody. I'm sure you all are tired and ready to go, so I'll try my best to keep this short. So, before I jump into the presentation, I think it's worth mentioning a few words about some of the studies that led to this work that I'm going to talk about today. A couple of presenters already talked about spinal cord injuries and spinal cord stimulation. My work actually started with spinal cord modeling related to Dr. Susan Hockema's work. So, they were actually using a 16 electrode array to stimulate spinal cord and spinal cord damaged patients. So as one of the presenters mentioned, there are different parameters to treat, stimulus amplitude and the configuration of electrodes. So what they usually do is they randomly pick different set of these combinations and try and see if it works. This is not very convenient. It's painful for the patient. Sometimes it's tiring. So the reason they do this is they don't know what's actually going on inside the spinal cord. So we decided to see if we could use electric field modeling and potential field modeling inside the spinal cord to visualize what's actually happening inside the spinal cord. Ultimately, you can correlate these stimulus to the actual neuron activation. So that's when we started to looking into different neuron models. So this is one part of that study we did. We looked at different spinal cord models. So here I'm going to talk about two of the models that we used and one of the studies we did using these two models. The first one is the Hodgkin-Huxley model. This is a pretty old model. They came up with this model in 1952. They actually won the Nobel Prize in 1963 for this model. It's old, but people still use this model because this model has a very good biological correlation. It actually models the actual neurons. So that's one of the reasons I started looking into this model. Now here I'm showing you the fundamental equation of this model, but this gets very complicated. So this is the actual model. So it contains a bunch of differential equations and parametric equations. Don't worry, I'm not going to talk about math. Just wanted to let you know it's a complicated model. The reason it's complicated is it actually has a biological correlation. Now here I'm showing you some of the action potentials actually going inside the neurons. That model can actually model these action potentials. So these are the signals that take signals from your brain to your hand and responses back to your brain. So the other model I'm going to talk about is called Ezekowicz model. This is a recently published model. It doesn't have any biological correlation. It's a mathematical model. The differentiation between this model and the previous model, Hodgkin-Huxley model, was intended to simulate something called type 2 behavior. Basically, it can simulate one type of an action potential that I've shown you in the previous slide. But this model can simulate different types of action potential. Action potentials can be just not a single spike. There's another category called bursting patterns. It's basically a group of action potentials repeatedly firing. So this model can actually simulate that. Now this is relatively simple compared to the other one. It only contains two differential equations and one condition. Now here I am showing you some of the action potentials that can be generated using a sequence model. It's not limited to single spikes. It can also demonstrate these bursting patterns, and this one is called spike trains. So we decided to see if we could actually generate bursting patterns demonstrated by a sequence model using Hodgkin-Huxley model. Because it has a biological correlation, if we can modify some of the parameters without adding additional parameters to the model, if we can optimize some of the parameters to generate bursting patterns, that would give us some biological correlation to those bursting patterns. So to do that, when we were doing experimentation, we found that by modifying some of these parameters in the parametric equations, in the Hodgkin-Huxley equations, we can get different bursting patterns and different action potential patterns. So these are the original equations in the model. So we decided to modify these equations. Basically, we parameterize these equations. So if you look at this alpha n equation, instead of 0.01, I've just converted it to a parameter. So I've done pretty much the same thing for all the parameters in these equations. So that gives me 23 parameters. Now when you actually do spinal cord stimulation, current can also play a factor. So we included current also as an optimizable parameter. So that gives us 24 optimizable parameters. Now we are trying to optimize these 24 parameters to get some sort of a bursting pattern. So these are my target bursting patterns. These were generated using a Sikowicz model. These are also observed in the literature, but I've used the results from the Sikowicz model because it's already quantified, so I can compare my results easily. Now, when you say optimization, what you're trying to do is you have some set of parameters you are trying to optimize, and you have a target. Combining these two, you have to come up with some sort of a function. Then what you're trying to do is you are trying to find some set of elements for this function such that it will give you a minimum value for your function or a maximum value for your function. If it's a minimum value, you call your function an error function. If it's a maximum, you call your function a fitness function. In this case, I'm using something called the error function. I'm just comparing my results versus my target. So there are different optimization methods you can use. One of the naive method is to use a brute force method. You just go through all the permutations you have. Now in this case, since I have 24 parameters, I'm just considering 23 coming from the Hodgkin-Huxley model. If I do that, if I consider each of these parameters have 4 possible values, that would give me 70 trillion permutations. That's limiting myself for 4 possible parameters. If I go for 10, it would give me lots more than that. So that's not a very good method. One of the other common methods when it comes to optimization is gradient descent method. Now I'm showing you a picture of 2 of my parameters with the error function. Now you can see there are so many local minimas. So if I use a gradient descent method, the optimization algorithm would get stuck in one of those local minimas and it wouldn't give me the best optimized value. So because of that, we try to use something called a genetic algorithm. Now if you don't know what a genetic algorithm is, it's related to the actual natural selection. So this is first mentioned in 1975 by Dr. Henry Holland. So in a genetic algorithm, what you do is you take your parameters that you're trying to optimize, then you create something called a chromosome using that parameter. There are different ways to encode these parameters, something called binary encoding, value encoding. Depending on your parameters, you choose a different encoding method. In my case, I've used something called value encoding. Then using this chromosome, you create population. Then population, you use a function, your error function. Based on that error value, you choose, you select a population. Out of that population, you select a subset. Using that subset, you create a set of offspring. Now, based on the fitness of those offspring, you do the selection again and again until you get your optimum result. Now here I am showing you a flow chart of the algorithm. So you start with initial population, you create the, calculate the fitness. If it does not satisfy your stopping criteria, you use a selection method. In my case, I've used something called roulette wheel selection. I'm not going to go into those details. Just wanted to let you know what's happening. Out of that selection, you find the best individuals. Then you do some sort of crossover and mutation. That's getting your offspring. Then you calculate the fitness again, and you do this over and over again until you find your optimum result. So in my case, to summarize, I had 24 optimizable parameters. Using those 24 optimizable parameters, I create a population of 200 individuals. Then I've used value encoding, then roulette wheel selection, and these are some of the parameters and values that I've used for generating offsprings. So ultimately, this is the target I was going for that came from a Sikevich model, and using the optimized parameters, I was able to get that result using the Hodgkin-Huxley model. If I calculate mean percentage error value between these two, it gives me a 5.8% error. The second target, this is my second target, and this is the result I got from Hodgkin-Huxley model with optimized parameters. So here I'm showing you the optimized parameters that I got. This column shows you the original values, and the other two columns shows you the optimized values for the two target bursting patterns. Now this shows you a correlation map of the 24 parameters with the error value. Now as you can see, up top is the +1, right here -0.25. As you can see, there's no linear correlation between any of these parameters, so any of the linear methods would not work to optimize these parameters. But if you use some of the other machine learning techniques, you can see right here I have population size, and this is the score that I'm getting using different algorithms. As I increase the population size, the score increases. Now I don't have a lot of data samples here. Maximum I have right here is 11,000, because in order to go through one generation, it takes about 45 seconds using the computers that I was using. So to get 10,000 generations, it takes up to 5 days. So it takes a really long time to do these simulations. I probably ran 500, 100 million generations to get up to this point. So in conclusion, I was using a genetic algorithm to optimize Hodgkin-Huxley parameters to see if I can expand the capabilities of the model. So ultimately, I've shown that it is possible to optimize those parameters. Thank you.
Very interesting work. Now, when you, in your final solution, it simulates the bursting.
Yeah.
Now, does it preserve normal spiking?
No, since I'm changing the parameters, it does not preserve the original value now, because it's limited to one output. Whatever model you're using, even the Sikevich model, you have to take some parameters in the model to change your output. So what I'm trying to say is, if I have a different set of parameters, I haven't done any verification stuff. If I can take this to a biologist who actually study neurons, maybe they can find correlation between the parameters that I found with the actual neurons. That's what I'm trying to say.
No other questions? Thank you.